So now we're going to talk about gestational diabetes. So what this is it's a type of diabetes that can occur when you are pregnant due to the physiologic changes that occur in your body during pregnancy. It affects between 1 to 14% of pregnant people. The latest data looking at Ontario midwifery clients from 2012 to 2013 shows about a 2.5% rate of gestational diabetes in our population. So, the hormones from your placenta lead to a temporary state of insulin resistance. This starts in the second trimester of pregnancy and continues until you have your baby. Insulin is the hormone in our bodies that regulates our blood sugar and allows us to use and store glucose. So, this mechanism makes sense as your body needs to send some of that glucose to your baby. A delayed glucose uptake is normal in pregnancy. Where it becomes problematic is if your body's not doing a good job at regulating it. So, gestational diabetes occurs when your body has a harder time getting sugar into the cells of your body than should typically occur in pregnancy. Higher levels of sugar in the bloodstream can be damaging to your body and your baby's body. So, treatment of diet and exercise is usually recommended depending on your blood sugar levels if you have gestational diabetes. A small number of people with gestational diabetes will require insulin or other drugs to control their blood sugar. There are some risk factors that can increase when you have gestational diabetes. So, people who develop diabetes in pregnancy are more likely to grow bigger babies, although sometimes they grow very small babies. The risk of stillbirth, preeclampsia, and cesarean section also increases for this population. Babies born to a birthing parent with gestational diabetes, among some other things, are more likely to have trouble balancing their blood sugars after birth, which can be serious and can occasionally lead to seizures. So the goal of treatment, therefore, is to control the birthing parent's blood sugar, help optimize the baby's growth, and mitigate these risk factors as much as possible. Okay, so what puts you at risk of having gestational diabetes? First of all, you're considered to be low risk of developing gestational diabetes if you are less than 25 years old, if you're Caucasian, if you have a lower BMI, so less than 27, if you do not have a personal or family history of gestational diabetes or type 1 or type 2 diabetes, and if you don't have a history of gestational diabetes associated adverse outcomes in a previous pregnancy, like, for example, polyhydramnios, which is an excessive amount of amniotic fluid that can sometimes develop. Risk factors that we look for are if you are over 35 years old, if you have a pre-pregnancy BMI of greater than 30, ethnicity can play a role. So people who are Aboriginal, African, Asian, Hispanic, or South Asian have an increased risk of developing gestational diabetes. If you have a family history of diabetes, some other pre-pregnancy conditions like polycystic ovarian syndrome or corticosteroid use can impact your chances of developing gestational diabetes. If you had it in a previous pregnancy, or if you had a macrosomic or large baby in your previous pregnancy. The recommended way that we test for gestational diabetes is with a two-step screening and then diagnosis approach. So the first step is the oral glucose challenge test, which screens people who may be at a higher risk for developing gestational diabetes. What this looks like is you get a sugary drink. It's 50 grams of glucose. It tastes like a melted freezy. We do this screen between 24 and 28 weeks gestational age. And what we do is you get the drink and then you hang out for an hour and we test your blood after 1 hour to measure the glucose levels in your blood. You can decline this screen. Your midwife will discuss your clinical picture and health history with you to help you decide. So if your oral glucose challenge test comes back elevated, you may be offered to progress the diagnostic tests. In some cases of extreme elevation, the oral glucose challenge test screen can be used as a diagnosis. The oral glucose tolerance test is what we use to actually diagnose gestational diabetes for the most part. So this one has some stricter guidelines surrounding it. What happens is you need to fast for 8 to 12 hours before you do this test. You go to the lab, they do your blood fasting. Then you have a even sugarier drink. It's 75 grams of glucose in this one. And then they test your blood 1 hour and 2 hours after you finish the drink. So we get 3 values of the glucose levels in your blood. And if any of those 3 values come back elevated, that is what we use as a diagnosis for gestational diabetes. If you're at a particularly high risk of developing gestational diabetes, then we can offer to skip the screen and just go straight for the diagnostic test. But for the most part, the oral glucose challenge test, that 50-gram one that we talked about, is a little bit easier for people to do. And for a lot of people, it's the only one they have to do. They don't need to progress to the oral glucose tolerance test. If the 2-step oral glucose challenge test and oral glucose tolerance test is not available, such as during the COVID-19 pandemic in some areas, you might be offered alternative screening, which consists of 1 blood draw, no drink, and it looks at a random blood glucose and a hemoglobin A1C, which looks at how much glucose your blood cells have been exposed to. And we can use this as an alternative approach to catching the people at highest risk for developing gestational diabetes in their pregnancy. Okay, so you've done the testing, you've been diagnosed with gestational diabetes. What next? Well, your midwife will arrange a consultation with the Diabetes Education Center. There you will meet with a dietitian and an endocrinologist, and they will help you learn how to manage your blood glucose based on diet and exercise, like we talked about at the very beginning of the video. Your midwives will discuss a care plan with you. This might involve a couple extra ultrasounds in the 3rd trimester to see how your baby is growing and how much amniotic fluid volume you have. We might recommend Colostrum Collection after 36 weeks. We can have some discussions about recommendations for inducing your labor and postpartum blood sugar monitoring for your baby, as well as blood sugar monitoring for yourself during labor and postpartum. If you require medical management of your gestational diabetes, so that's insulin most commonly, although also it can be things like metformin, this is an indication for a transfer of care from your midwives to an obstetrician for the remainder of your pregnancy. And that's because the risk factors that are associated with gestational diabetes, they're just more prevalent if we're not able to adequately control your blood sugar levels. So in this case, your midwives will work with you to create a supportive care plan for your birth. And then as long as everything returns to normal, we'll likely resume your care and the care of your baby in the postpartum. So I've linked a bunch of things, of course, about gestational diabetes in the description below, as well as some information about Colostrum Collection. Just in general, actually, Colostrum Collection is a really great way to get to know your body and to be comfortable with your breast and chest tissue as you get closer to your due date. I usually recommend people starting this once they're term and not beforehand because it can cause some uterine cramping. But take a look at these things and talk to your midwife about any questions that you have.